We would like to welcome each one of you to our 7th annual Emergency Preparedness Seminar hosted by CHCANYS, Community Healthcare Association of New York. For the very first time, we are also streaming live. Hello, everybody who's watching online via YouTube. We have about 100 people attending in person and about 100 plus attending virtually, at least supposed to. So keep an eye on that and behave, those in the audience. Community Healthcare Association is the New York's primary care association, representing about 80 federally qualified health centers, community health centers, who serve about 2.3 million patients annually. So the theme of today's seminar is resilience. The resilience in many aspects: personal, professional, programmatic, organizational. Why did we choose this theme? Oxford Dictionary gives us a definition of resilience as capacity to recover quickly from difficulties and toughness. We're more than 2 years into the pandemic, which is still ongoing. We're very happy to be here without masks, but everybody's vaccinated, so there's still some progress. Those who do want to wear a mask, we do respect that. Thank you. 2 days ago, we had a crazy shooting attack in the subway. You're all aware about that. We are 50 days on the world stage in the war with Ukraine. I want to mention that as well. So the world is not necessarily what we would like it to see and be. That's why we need all of you and all of us to be strong and remain strong. So there's no doubt that FQHCs are resilient and tough. New York FQHCs are New York tough, I will say that. But we still need encouragement, support, inspiration, learning. That's why we're here today. Couple of housekeeping items to keep us all organized. We are streaming this event via YouTube. Those watching live, there's limited interaction, but please use email emteam@chcanys.org, emteam@chcanys.org if you want to participate and submit questions and comments. We have a staff person assigned to monitor that. Today's program is being recorded. Those who could not be here with us today will be able to watch it. The slides we're using today will be shared to all registered attendees following the event. Give us a few days to do that. In your folders, all of you in the room, I mentioned already there's a pre-test colored green. Please take a second to fill it out. After the program or before you leave, please submit a post-test and an evaluation. It's really important. That's how we know what we're doing well or not well. Don't leave today without submitting all those 3 things. In the folder, there's also an agenda, handouts for one of the sessions, flyers, so please do have a look. There's also note pages for you to take notes. We have pens if you need them, etc. Wi-Fi is available. I hope you had a chance to grab the network. Network is Baruch Events, password, conference, center, no spaces, all one word, no small characters. There's breakfast. We'll be providing lunch at about 12. We'll see if additional breaks are needed based on your participation and fatigue level, so please stay tuned on that. There are microphones in the room. We have AV folks here, so we'll ask you to speak into the mic. Nobody is loud enough for the room, I'll tell you that, and for the internet. So it's absolutely important you use the mic. Emergency exits are clearly marked. This is an emergency preparedness seminar after all. Bathrooms are through that door all the way to the back if you haven't had a chance to discover those. And we have a coat closet over there on my left if you want to hang something. The weather is nice, so maybe you brought a jacket and you didn't have to. There's also supposed to be rain later, so just an FYI. There's a bunch of staff, CHCANYS, wearing purple, I guess, badges, so please ask us. And myself, Radamas, Adriana, and Sue downstairs, who you have met, and Salman is helping us offline, online, but remotely. And if you have any questions, comments following the program, please email us at emteam@chcanys.org. Before we get started, I want to express our gratitude to a bunch of entities. To all of you, FQHC staff, NPCA staff, and friends and partners for being here with us today, for pushing forward the care for patients for 2 years ongoing plus. We thank you for doing the work on the front lines. To Baruch College for this fabulous hosting room, 7th annual. We like to return here, and it's a bit weird to be back after so many years. It feels like crazy long time, but we're here. Thank you, Baruch and their staff. We'd like to thank New York City Department of Health and Mental Hygiene, without whose support this program would not have been possible at all. So we appreciate your partnership and all the support your staff is giving us, CHCANYS, to fulfill the program. And again, to our guests who are not FQHCs and speakers as well for spending your time here with us. Speaking of speakers, it's my honor and pleasure to introduce our next presenter, Dr. Duncan Maru. Dr. Duncan is the Assistant Commissioner for the Bureau of Equitable Health Systems in the Center for Health Equity and Community Wellness at New York City Department of Health and Mental Hygiene. This bureau works with primary care providers, hospitals, payers, and other healthcare systems to address structural racism and implement evidence-based strategies. Dr. Maru is an epidemiologist and physician trained in internal medicine and pediatrics. He is an associate professor in the Department of Global Health at Mount Sinai. He also continues to teach and practice clinically at NYC Health and Hospital System at Elmhurst Hospital Center. So, Dr. Maru, the floor is yours. Enjoy, and thank you for being here with us.
Good morning, everybody. Good morning. All right, well, it is really an honor for me to be here. I wanted to start by opening the space with a bit of an invitation to a moment of grounding. So if you all might put down your food for a moment and your coffees, and those of us online, welcome as well. And just maybe close your eyes and take a deep breath. And just to acknowledge and remember our ancestors, to acknowledge this land that is unceded, indigenous land. And maybe bring to mind someone in your life, maybe it's a coworker, maybe it's a neighbor, maybe it's a family member, somebody that maybe has evoked some amount of frustration with you. Maybe they have been susceptible to misinformation and share their thoughts with you. Somebody that you've struggled with in this journey of collective well-being and trust throughout the pandemic. Maybe somebody like my little brother who, despite all of my encouragement, still won't go to the dentist or get his COVID vaccine, but still whom I love unconditionally. And so think of that person and think about how can we collectively make our communities whole? How can we serve the public good? And how can we heal each other? And invite that person into your space today to remind us that the root word of health is heal, and that we are all public health healers. So you can open your eyes. And thank you for that. So I'll share a few thoughts, and I just invite folks. I'll share about hopefully no more than about 10 minutes of thoughts, and open it up to the audience for any kind of comments or questions or invitations for today. And those online, you can put stuff in the chat to the moderators. but I wanted to just share really three thoughts, and to acknowledge that I am certainly probably the least expert on the topic in the room. As mentioned, I'm an internist and pediatrician, and I only recently came to the health department after becoming a COVID doctor during the original surge, and bearing witness to what can only be termed a humanitarian crisis that we as a city faced, and the trauma that families went through, that patients went through, that health workers went through, where I found myself as a doctor doing oral care on dying patients because we had no respiratory therapists, and we had minimal nursing staff, we had minimal physicians, where I consoled our residents who would literally find people dead on morning rounds. And so, and really being inspired to take this moment to memorialize those we lost and to take it forward. And I think that's the meaning of resilience. I'll also say that I had the real honor of working for about the last 15 years with colleagues in Nepal on various healthcare system strengthening, community health worker, and public hospital building efforts. And I really came to the health department in memory to a dear colleague and brother, Siddharth, who died by suicide in June 2020, in part as a healthcare worker, in part as part of the pandemic, and in part because of the organizational structures and systems that we've created that don't do enough to support the public health and healthcare workforce. So I have little to share and I don't believe that this our seminar today I don't believe we'll come out with a roadmap, but I think perhaps an invitation for us to take this moment to build stronger health systems that care for our workers and care for our communities. So I really pose sort of three questions. The first is, how do we tie worker justice to health equity? And how do we really understand that those are two sides of the same coin? That we can't have situations where we have one respiratory therapist for 80 ventilated patients again, or that we can't have primary care clinics that are understaffed and under-resourced. So how do we get the tools for those health workers, and how do we help support them to care for communities? And I really view this as a spiritual question for medicine. I carry various hats, but one of the professions I carry is that of medicine. And this connection between worker justice and health equity for me is really a spiritual question about the spiritual misdirection of our profession, how we allowed ourselves to be in this situation where, based on your race, your neighborhood, your insurance status, your immigration status, you could live or die, and how my profession has, in fact, profited off of that. So, and I don't believe the city has, our DOH&MH has the answers, and so I'm inviting everyone to help us in that journey of connecting worker justice and health equity. The second piece is related, which is around process decentralization. I think one of the really important movements in public health practice is that we are starting to recognize that we as public health practitioners, or we in, say, the city Department of Health, are not the experts. As a pediatric palliative care doctor, in my previous clinical role, the families of those patients and those kids really taught me, if I ever walked in the room and I said, look, I know what's the best for your child, this is what you need to do, I would get kicked out, because they've been running a nursing home in their one-bedroom apartment in South Boston for 10 years. They know their child, and no, doctor, you do not own my child's personhood. So how do we show up in our communities with a sense of humility and a sense of respect for the fact that communities know what they need and they know the resources they have? And one aspect of that within organizations, I would say within a city bureaucracy, among them, is process decentralization. How do we set up structures that roll up through signatory authority up the chain? In many in the nonprofit sector, that chain rolls up to people making upwards of 7 figures in the healthcare system, which to me is spiritually not right. So how do we, when we talk about the people closest to the problem, need to be the voices telling us about the solutions and creating those solutions and having the authority to create those solutions, how do we do that? That's if I were to say what am I doing for the next 5 years of my life in city government, that's sort of my thesis. And can high-performing decentralized bureaucracies and spiritual transformation be, again, two sides of the same coin? And then the third one, again, related to worker justice and health equity and process decentralization, is how do we embed relationships in our kind of routine primary care operations so that we can rely on and we have resiliency and backup and coverage and worker protections of our existing primary care infrastructure, so that, for example, what happened during the surge, we can prevent, where I can say at some of our hospitals, having the Army come in, having FEMA come in was a lifeline. It was transformative. We were so grateful. But how can we be in a position where we don't need to call in the Army or FEMA? And that, I believe, is through building relationships with each other, with communities, and for those of us on the payment side and the government side, how do we create the right incentives and payment structures to support those relationships? So those are my 3 comments, and I will open it up. I have maybe about 5 minutes or so for any kind of comments or questions or invitations for the group. Thank you. And if anybody online has put anything in the chat, I can't see you, but.
Any questions from the audience? There's nothing online yet. We have one question.
Or comments, or ideas.
Thank you for your discussion about this. I'd like to know what you would recommend for health centers in terms of encouraging providers to have the same approach you do, because it is, I think we've all changed because of COVID, but we're a long ways off from truly looking at healthcare as a holistic healthcare delivery system. So I welcome any thoughts on how you feel you can transform or help inspire other providers to think the way you do.
Well, yeah, I might pivot the question and say I'm not necessarily sure we want providers to think the way I do, but I do appreciate that. I receive that. And I appreciate the sentiment, and I will say I believe that I understand what you're saying, which is that we providers, and when I say we providers, I mean I'm gonna speak specifically about physicians. I think because our physician education is really, really deeply problematic. Now, it's improved a lot since a couple decades ago when I was in medical school, but we really, I think, one, and I talk with my colleagues at the health department about this a lot, which is, one, doctors are trained in diseases. We're not trained in personhood. And so I think one part of it is certainly working with medical schools and residency programs, and I would say, for myself, just having these conversations, creating groups with providers, and being part of resident and medical education is, sort of really conversation by conversation. I really do kind of believe that a lot, that what again I will just call spiritual transformation among doctors can't happen from sort of a top-down dictum. So a lot of it is sort of creating spaces for conversations and then continuing those. And some of those conversations have been, really catalyzed by other social movements. So I'll just say in the last 5 years, or a little bit, 5+ years, several years, the Me Too movements, Black Lives Matter movements have really shaped American academic medical centers, and in very good ways. I will also say, in terms of what we can do from a policy perspective, just being on some of these, for example, anti-racism task force within academic medical centers, whenever the conversation turns to, it moves from diversity, equity, inclusion to racism embedded in our business models, we kind of hit a bit of a road. Or when it turns to, how does the fact that we have physicians making millions of dollars, or a physician executive making millions of dollars, how does that spiritually erode our healthcare system? Again, that's not in my darker moments post-COVID, I definitely tried to write certain policy agendas around physician compensation because it really bothers me, but I don't have any solutions on that. But I would say I think a lot of it is opening spaces of just that we create spaces to have these conversations in our clinics, in our health centers, in our hospitals, in our places of education, and then along the way also just changing how healthcare is financed. I mean, we created a system where a cardiologist can make $4 million in New York City, and that is, again, to me, is spiritually wrong. I don't know if I'm right from a policy perspective, or maybe there's something that just like that's the nature of the world, that it should be that way. But again, to me, that spiritually is wrong. So
I think we have time for one more comment or question. Barbara.
Good morning again, Doctor, and thank you for setting the tone for this morning. Appreciate that very much. I wanted, if you have an opportunity to speak to us a little bit more about process decentralization, if you observed any of that while, in your experience working as a COVID doctor, if you've given any thought to what that could look like moving forward. Any examples of that we could even bring it down to community health would be really appreciated.
Yeah, I think that's trying to give you a concrete example of this. I think. Well, let me kind of give you two. One is that and I want to actually acknowledge and thank anyone who is a partner of the DOH, New York City DOH. That I acknowledge that we do struggle to get through contracts, pay our bills on time, be effective partners. And I will say part of that is because we've embedded a deep system that goes back decades that was, perhaps originally anti-corruption, but then became this concept of signatory authority within government hierarchies. And that's something that, within our bureau, I honestly will say to teams like, look, I have a very high risk tolerance being a doctor because I believe you have to advocate for your patients. And I will pretty much sign whatever you want. If you want to involve me so I don't become a bottleneck in the process, if you want to involve me in the conversation over the course of months or whatever about how you got to whatever I need to sign, I'd love to do that. But otherwise, if you put something on my desk, I'll sign it because I trust you. And it's a kind of a concept that you all may be familiar with from Lao Tzu of trust the people and they will become trustworthy. And really, can we embed that in how we operate in our organizations? And first and foremost, I would say, at least within the sort of self-improvement within government. I'll also say, one of the things I really struggle with as a doctor this was more in the second wave, but we had these family visitation policies that were, you can only have one family visit from 3 to 7. And, frankly, I think that was one of these kind of concepts that is really set up to protect the interests of the hospital rather than the interests of the patients. Patients by that time, this is the second wave, they know the risks. They want to be with their loved one who's in the hospital with dementia. They want to be with their grandfather who is dying of leukemia. They want to be there, and they will take the risk. They will put on the PPE, and they will take the risk. And so, so as a doctor, I would say, look, talk to the administrator on duty. If you won't let them in, I'll just go walk. I'll go down to the border and walk them up. And so, but we have to be willing to sort of listen to what the patient's needs are. I really, and that's it sounds like a small process, but family visitation, how important it is. When my father-in-law, who I've lived with for 15 years, when he was in the hospital, he has Parkinson's, and his wife, my mother-in-law, was by his side, living at the bedside literally did not go home for 45 days. Literally did not go home. And the reason why he survived and why today he can walk in Jackson Heights down to the Jain Temple and he can be part of the family is because she was there. And she would have died. Our system would have killed him. And so I think just trying to, how do we sort of listen to those patient advocates? I really do think that, that the bedside nurses, the respiratory therapists, the medical assistants in primary care setting, the nurse practitioners, folks want to heal. They want to be healers. And so how do we set up organizations that are able to listen to them and be more adaptive rather than sort of saying, well, there's a process, follow the law, and sort of that we in our journey to, being compliant with XYZ rules or regulations, we forget what the original intent was, which is to heal and to advance health equity. So,
Dr. Maru, we have one more question. If you could stay on the podium. From
Okay.
our online audience, I want to acknowledge them.
okay.
We have a question coming from upstate New York. In a couple of minutes, if you could answer this. In a system so based in metrics and data, how do we enmesh that importance you're talking about with the personal human aspect of care when we have 10 minutes with patients for what could be several areas of care need? I don't know if you could use a couple of minutes for this huge question, but if you could respond to that quickly.
That is a beautiful, beautiful question. Yeah, I think one of the things that we should recognize when we talk about metrics is ultimately our goal is accountability, and what's the accountability to? Again, it's to our communities, our families, the folks who are sick and asking for help. Yeah, I mean, all I can say is I think one piece is how do we embed in our institutions places where that sort of non-metric, kind of qualitative and narrative conversations can emerge. I mean, but I would say, I think what you're getting at is from a payment system, like, you're like, okay, doc, all your nice spiritual ideas are great, but at the end of the day, I'm attendant to these RVUs. And yeah, I mean, I think that is a really fundamental journey. I don't have an answer to it other than to say that I think you're absolutely right. I think metrics are important, data are important, but it's not just numbers. It's also, data are also stories, and data are also experiences. And we have to remember that even if we say, okay, our goal is to improve equity in diabetes outcomes, improve equity in COVID hospitalizations, improve equity in mortality, improve equity in severe maternal morbidity, I think it is critical that we as a society track these and hold ourselves accountable to them. And at the same time, remember that people's experiences of care is so vital, and how do we, and we have various ways of measuring experience of care and that, but beyond those measurements, how do we embed those in our systems? And I think it's a wonderful question and something that certainly I will keep thinking about. So thank you. Thank you.